Welcome to Robert Wood Johnson University Hospital Somerset's Health Talk. I am Dr. Douglas Ashinsky of RWJBarnabas Health Medical Group. According to the American Cancer Society, 1 in 3 of us will be diagnosed with cancer in our lifetimes. On today's show, we will discuss the most common types of cancer, recent advances in care, the latest screening recommendations, and navigating cancer care during the COVID-19 pandemic. We are pleased to be joined today by Dr. Kathleen Toomey, a medical oncologist who is the medical director of the Steeplechase Cancer Center at Robert Wood Johnson University Hospital, Somerset, and has recently joined the RWJBarnabas Health Medical Group. In accordance with social distancing due to the COVID-19 pandemic, Dr. Toomey will be joining us remotely via video conferencing. Thank you, Dr. Kathleen Toomey, for coming to join us. I wanted the audience here to learn a little bit about you, your background, etc. I don't know if you know, but I started practicing medicine approximately the same time as you did back in 1987 also here, and have been thrilled about using you and your group as consults for my patients. But tell us a little bit about yourself and about your new medical oncology practice.
So thank you, Doug. So happy to be here with you. And yes, it was 1987 when I went into private practice. I trained in New Brunswick at St. Peter's University Hospital and Middlesex General at the time, now Robert Wood Johnson University Hospital, and went into private practice and practiced at RWJ Somerset from 1987 and have had a wonderful, wonderful time here. I call it the hospital, the Cheers Hospital, where everyone knows your name. So it's a wonderful place to have practice. And now I'm continuing to practice with RWJBarnabas and the Cancer Institute of New Jersey in oncology and hematology, bringing cancer and blood disorder care to the Steeplechase Cancer Center here at RWJBarnabas Health.
Thank you very much. And just so the audience knows, since we are talking about cancer, can we have a definition of what exactly cancer is?
So cancer is many, many, many diseases, obviously, because there's many different kinds of cancer. But basically, people think that cancer cells grow faster than normal cells. It's not that. It's that they grow without respecting other organs. Cancer cells tend to grow within organs. They tend to spread to other organs. So it's usually mutations within normal cells that then cause uncontrolled growth.
And the most common cancers for both men, women, and who's at risk, and maybe even the age groups that we should be looking at certain things.
So the most common cancers for women are breast cancers, and the most common cancers for men is prostate cancer. So those are 2 hormone-driven cancers that we see the older one gets. So the age group, as we get older, our risk of any cancer goes up, but those 2 cancers specifically. The other cancers that we see most commonly are the colorectal cancers, and that's both for men and women. Lung cancer is a very relatively common cancer, and unfortunately the number 1 killer of both men and women. So those are I would say the big 3. We also see hematologic cancers like lymphomas and multiple myeloma. So there are blood cancers that we see. So I think those are the most common cancers. And age group is usually, once again, the older we are, our immune system goes down. So cancer cells, mutations that happen don't get fixed by our immune system. So we are at increased risk as we get older.
And over the past 4 decades since you've been in practice, you've seen significant advances in cancer care that have led to much, much better patient outcomes. Can you tell us what you think has been the major milestones in cancer care during the last 4 decades?
So when we started, we were curing a little less than 50% of all people with cancer. Today, it's over 70%. So I do see the forest for the trees. I do see tremendous changes in terms of cancer survivorship, of curing cancer, of people living longer with cancer, of us having much better medications around taking care of side effects of cancer and side effects of treatment. I always use the example of chronic myelogenous leukemia. When I first started, a patient diagnosed with chronic myelogenous leukemia had a median lifespan of 4 years. Now, their lifespan is the same as the general population. So we took a disease that was highly, highly deadly, and we made it into a lifelong chronic condition. I just saw a lady yesterday here who actually has moved to Somerville from out of state, and she was diagnosed 20 years ago with chronic myelogenous leukemia, taking her medicine. She's doing perfectly fine. So that's one example. The other example of changes, we're getting away from chemotherapy and we're getting more into molecular biology therapy, looking at the cancers, looking at the mutations within the cancers and picking each mutation and getting a targeted therapy for that. Quite often these targeted therapies are pills that people take. It's not intravenous anymore. And then another even newer way of treating cancer is immunotherapy. So I think people see on TV these ads for Keytruda, those kinds of drugs for lung cancer. These are medications that don't make people sick. They don't lose their hair. They don't get nauseous. They don't drop their blood counts. We can give it to people who are quite elderly. And when they work, they can really be a home run. So people can go into complete remission from their cancers and remain there for long periods of time. So I have absolutely seen many, many, many advances. You know, the good news is that we have lots of new drugs. The bad news is that we have lots of new drugs, so we need to know what to do with them and how to use them and when to use them, it's called precision medicine, how to be precise about each and every patient. So we have, for example, the immunotherapy drugs were the first drugs that we had that we didn't have to know what kind of cancer somebody had. We just had to know what their levels were in their cancers that they could fight, that they could be using immunotherapy to fight their cancer. So things have changed tremendously in the last 40 years. It's been very, very exciting. So our new problem is survivorship. How do we deal with the survivors and what can we do to make their lives better? Minimize side effects. We are doing clinical trials now that de-escalate therapy, that take therapy down. What's not too much, not too little, just right. How much do we need to cure somebody, but avoid too much so that we don't cause any unwanted side effects?
Which again leads us into your changes. As we mentioned, you are the medical director of the Steeplechase Cancer Center, and were very, very, very instrumental in the development of this center, which opened in 2007. You're now the director of you're now part of the Robert Wood Johnson University, Somerset, and Rutgers Cancer Institute, which is the only NCI-designated comprehensive cancer center in New Jersey. And you were talking about survivorship, partnerships, etc. So what are the benefits now of the partnership between this NCI-designated comprehensive cancer center and Steeplechase Cancer Center in Somerset?
So we have been partners with the Rutgers Cancer Institute of New Jersey for a long time now, and that has given us the ability to have clinical trials locally, as well as the ability to have our patients see experts in any single disease, such as leukemia, lymphoma, rare tumors. It's one thing to treat breast cancer and colon cancer and lung cancer. Those are everyday cancers. But if somebody comes up with a sarcoma, for example, a rare tumor, we have the availability of having local experts. This way, patients don't need to travel to Philadelphia or New York or Maryland or Seattle, Washington, or wherever else they might have gone in the past to get expert opinions and expert care. So having a tertiary care center within 10 miles of our hospital has made it so much easier for patients, because we all know that when you have cancer, traveling long distances is not what you want to be doing. You do not want to be in a car going over bridges and on turnpikes, and it's hard enough to get to your local place rather than having to travel long distances. So we are very happy to have the availability of clinical trials locally, to have the availability of clinical trials such as phase 1 trials very close to home for our patients, and to have the availability of experts with whom we work collaboratively. And so I'm very happy to continue that relationship and to have that relationship grow.
We're now a multidisciplinary cancer center, as good as anyone else. We are not second to anyone. And
Correct.
And we're community-based as well as based in New Brunswick, allowing patients to be treated within their own community, not having to take 2 hours to travel into New York, find a parking space if you're lucky, and get a ticket after you've left your car there for too long because it took longer than you thought you did. And seeing that person only one time, and then you have a question and you can't even get back to that person. So we have this whole multidisciplinary, community-based center that has everything possible to treat our cancers. We have the advanced therapies. We have the rare and that can treat the rare and complex cancer cases, and they're close to home. We have the expansion of the oncology services at the Steeplechase Cancer Center, bringing these specialists to our communities. We have things that no other institution in New Jersey has.
Absolutely. And we have it in an atmosphere that is very warm and welcoming, and with ease of parking. As you mentioned, parking, park right in front. We have a concierge who greets you. We have a boutique where patients can get their bras and prosthesis and wigs and turbans and special bathing suits, and a fitter for lymphedema garments and compression garments, and once again in a warm, welcoming place, because having cancer is scary enough. We don't need the place to be scary. So we're very proud of that type of culture at the Steeplechase Cancer Center, and that started from day one, and that has continued to grow. Very proud of our multidisciplinary team. So every week we have and I already did that this morning from 7 to 8 with our early bird surgeons. We have a meeting on breast cancer weekly. We have a monthly lung cancer multidisciplinary team, colorectal cancer multidisciplinary team, a kidney, prostate cancer multidisciplinary team. And in these teams, the radiation therapists, the medical oncologists, the radiologists, the pathologists, the research personnel, the social work personnel, the nurse navigators, everyone gets together and we discuss individual cases and come to a consensus as to the very best treatment. We look at clinical trials for the patients. We look at what community resources are available for the patients. We were talking this morning about Reach to Recovery, which is an American Cancer Society program for women who've had breast surgery, referrals, and how do you get everything you can get for your patient, from the best medical care to all of the best supportive services. I'm very proud of the supportive services at the Steeplechase Cancer Center, the support groups for men, for women, for people with specific diseases, multiple myeloma, myelodysplastic syndromes. Our men's cancer support group is amazing, and now meeting virtually, but meeting 3 times a month. Yoga, Tai Chi, exercise classes. We have many, many, many supportive services right at the Steeplechase Cancer Center. So very proud of our multidisciplinary teams and our multidisciplinary way of treating cancer.
as well as the tumor boards, which most people don't understand, where you're bringing everyone into the patient. Basically, you're presenting the patient, presenting the cancer, presenting then all different points of view of how to treat this patient, getting second opinions, third opinions, and coming up with the most, what everyone feels is the best way to treat this patient. So you're not just dealing with one oncologist, one radiologist who may have a thought process. You're dealing with so many different opinions that you're getting the best opinion out there, and that once that opinion is agreed upon, first, the patient still has options to get second opinions after they come up with this opinion, but you can then present to the patient everything from soup to nuts on how we can initiate this treatment, how we can do this treatment, and how we can follow up this treatment in a local community.
So absolutely. So our cancer conference, as you say, meets twice a month, but all of our multidisciplinary teams, that's exactly how it works. We present the case, and everyone's opinion is important. I always say 100 are always smarter than one. So everyone, and we seek opinions from everyone as to how we can help this patient, what the best course of care would be. And then if many of the physicians have really bought into coming to these multidisciplinary teams and cancer conferences because they do get help, right? We're not alone in our little silos. We are all interconnected. And when you see the pathology and you see the x-rays and you have other opinions, it really helps in charting a very good course for our patients. There's always someone who comes up with some good idea at each and every one of these conferences. So it's wonderful for our patients, and our patients love it. The whole idea that many people are looking at their case makes them feel so much better that they know everyone agrees that this is the best treatment for them.
And what's also exciting about it is you also invite the primary care to the conference also. So they may not understand what's going on, but they can hear the different opinions, and at the end of the conference understand what the steps are for their patient's cancer. Again, something that's not done at many other institutions.
I've heard that many times, and once again, I'm very proud of having been involved in the development of this program, and we love having the primary care physician come and giving their input as to the patient, talking about where the patient is coming from, the family dynamic, and what barriers there might be to, taking care of this patient. The primary input is just so important. Love it when they come. Love it.
And the other thing that both Steeplechase Cancer Center have, as well as Rutgers Cancer Center, is an important oncology nurse navigator. Do you want to tell us a little bit about what an oncology nurse navigator is and how it really helps that patient get through?
So my motto is it takes a village to take care of a cancer patient. There are so many needs. And our nurse navigators are tremendous helps to us of getting the patient number one, getting the patient to the treatment. So they navigate the patient to get their appointments. They navigate the patient to get their testing done. They navigate the doctors and the patients to getting together in a very quick and efficient timeline. We could not operate without them. We have a nurse navigator in breast because breast is such a big program. And then we have a nurse navigator for other cancers. We have navigators and nurse practitioners who work in GYN oncology and in lung oncology and in breast oncology. And all of these nurses, and the navigators are usually nurses, are amazingly helpful to both the patient, the family, and to the whole team.
And what I find out a lot is that when I do refer my patient to Steeplechase Cancer Center, to the nurse navigator, how well organized it is, how they get all of the information together, how they are able to help the patient get an appointment, how they're able to work with the patient, with the social workers, with the financial planners, making sure that everything that's done is covered by the insurance. There's nothing in the world like that, because when you say that word cancer, after that, the person really does not hear anything else other than that word. And having that person, that nurse navigator, plus everything else that Steeplechase Cancer Center has, as well as Rutgers Cancer Institute has, allows that patient to continue through the course of treatment and have these people standing up for them.
Exactly right. They are patient advocates, and they also connect the patient to any community resources that there might be. And especially for patients who have difficulty with insurance, difficulty with jobs. And the other thing I want to mention is that I appreciate even more these nurse navigators during COVID. These nurse navigators grabbed on and worked hard, and all of the extra barriers that were put up by the pandemic. Families can't go in with patients when they're getting their visits, keeping the number of people in the facility to the minimum. But the nurse navigators were there. They were the patient advocate. They helped the patients and families to understand what's going on. It's an invaluable service. There's no doubt about that.
Now, getting back to the COVID-19 pandemic, unfortunately, many people have put off doing their screenings because of it. And now that things are opening up and we are able to do more, and even at the hospital, you may be able to have someone come in with you occasionally. What are the screenings that people should remember to start doing again? And why is it important not to delay these screenings?
Well, that's exactly right. I mean, the problems come on both sides, because on the one hand, people are leery of coming to healthcare facilities. And on the other side, the facilities are doing everything possible to keep people safe. As more and more of us are vaccinated, and certainly as more and more of the healthcare professionals are vaccinated, things become obviously much safer. For some of my patients, it's okay, I'm going to wait till I get the vaccine to come for my screening. But then we have a tsunami of screenings, right, of people who put things off. And now many, many more people, are coming back. But certainly colonoscopy, I think, would be number 1, 2, 3, and 5, because colonoscopy is the one cancer screening that prevents cancer. So colonoscopy, by doing it correctly, you have a polyp taken out, and it doesn't become a cancer. So we see colon and rectal cancer going down in incidence because people can get colonoscopies. We're all actually worried right now about all of the people who have put off their screenings. So I always talk about colonoscopy first. The second thing is mammograms and breast cancer screening. So there are many more people who should have their mammograms done, and that should be done on an annual basis, and that's from age 40. And so that's another area that we worry about people having put off. I think the third would be the pap smear and the gynecologic exams. So those are exams in person. So I would say those are the big three. There is also lung cancer screening for those who smoke. And that's a really important screening to have done. So long-term smokers over the age of 55 can have a yearly low-dose CAT scan to screen for lung cancer. So I would put those 4, I guess, at the top of my list.
Again, as a primary care physician, now that people are beginning to call in again, important thing is if there is a history of cancer of the colon, is to make sure in the family is to get the colonoscopy done. 2, for screenings, again, people who are 50 or above, making sure they get their colonoscopy, and then follow-ups based on what we see on the initial colonoscopy. And there are many excellent gastroenterologists and colorectal surgeons who are part of Robert Wood Johnson Barnabas Health, who do them either as outpatients or in the hospital if necessary. And again, very good cancer screenings, because if we do find any abnormal cells or polyps, we can remove it before they do become any type of cancer or abnormal growths. Mammograms, again, very, very important. And unfortunately, due to the pandemic, many women did put them off, and it's important that they get back into doing their yearly mammograms. And there's nothing like sending people to Steeplechase where they can get a 3D mammogram done and you get a report done very well, and they also contact both the primary care and the patient to alert them if anything else is necessary. Getting back to their gynecologists every 2 to 3 years based on whatever their previous pelvic pap smears had shown, getting HPV testing done also to ensure that we're missing anything. Then, of course, just the routine type of care that needs to be done, reducing low-fat, low-cholesterol diet, increasing vegetarian type of foods in order to reduce the possibility of developing cancers. The other big question that many patients have when they come into the office now is if they have cancer or if they're treated for cancer, should they get the COVID-19 vaccine? Your opinion?
Okay, so my opinion is yes, yes, and yes. Obviously, we take the vaccine to help ourselves, we take the vaccine to help our families, and then we take the vaccine to help the community. Cancer patients are at increased risk, and if they have COVID, they're at increased risk of dying. So my cancer patients are all anxiously awaiting or have gotten the vaccine. I speak to each and every patient about the importance of the vaccine. There is only one group that we advise not to have the vaccine, and those are patients who have had an allogeneic or from somebody else bone marrow transplant. So if you've had a bone marrow transplant, you have to wait a year to get all your routine vaccines. So that's the only group. But my patients who are getting chemotherapy get the vaccine. Unfortunately, the vaccine might be slightly less effective in them, maybe from 90% to 75%. But once again, if they get the vaccine and they get COVID, they don't go to the hospital and they don't die. So I strongly urge all of my patients, all of their families, everyone who works anywhere in healthcare to have the vaccine. And that's a mantra that we've been talking about for a long time.
And of course, they should be getting all their other vaccines, also the yearly flu vaccine. If they're above the age of 65, making sure they get their pneumonia vaccine, both the Pneumovax 23 as well as the Prevnar 13. If they're above the age of 50, also getting the shingles vaccine. Again, if we can do things to prevent them from ending up in the hospital during a pandemic or after a pandemic, we would be more than happy to have that happen.
Absolutely, absolutely. It's just, as I say, the risks are tiny, the benefits are huge. It's a no-brainer, as the kids would say.
And if we all do this, maybe sometime down the road, you will be able to hug your grandma, your grandpa, or your kids. You may be able to actually do things closer to what we had been doing 2 years ago.
That's the hope, right? That's the hope. We'll get there. We're about, 40% herd immunity. Half of us have had the vaccine and half of us have had COVID in New Jersey. So about 20% have had COVID and 20% have had the vaccine. We need to be 90%. So we need to continue to get to herd immunity and continue to make sure that we are all responsible to everyone else. So it's our responsibility to help all of us. It's not about me. It's about everybody around me. For me, it's about my patients, right? I have to be protected so I can protect my patients.
Well, thank you very much, Dr. Toomey, for being here. Thank you for all of your expertise. Thank you for being who you are since 1987. Thank you for helping to be the medical director of the Steeplechase Cancer Center, as well as still seeing patients and taking care of them to the best of your possibility. And also, congratulations on your new position as part of RWJBarnabas Health and Rutgers Cancer Institute of New Jersey.
Well, thank you, Doug, and it's so good to see you once again. Take care.
This concludes today's episode of Robert Wood Johnson University Hospital Somerset's Health Talk. Please remember that the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral line at 888-724-7123. For more information about cancer services at Robert Wood Johnson University Hospital Somerset, please visit us at www.rwjbh.org/Somerset.